Timbre is a unique quality of sound. Two particular sound waves may have the same frequency, but they will differ in quality. For example, a key of C in the piano would have a different quality with that of the key of C in the violin. Music is regularly repeated wave patterns, whereas noise are non-periodic vibrations. In localizing sound, the pattern of neural stimulation is analyzed by the superior olivary nucleus. For example, if the sound is coming from the right, then the right ear would hear the sound first before the left ear. The time difference will be analyzed by the medial superior olivary nucleus. Then the brain will interpret this as the sound coming from the right. For the difference in the phase of the sound, if the crest of the sound hits the right ear and the throw of the sound hits the left ear, the medial superior olivary nucleus will interpret this as the sound coming from the right. This is particularly important for low frequency sound waves. For the differences in intensities, if the sound is coming from the right, then the right ear will hear the sound more loudly compared to the left because the head will muffle the sound. The lateral superior olivary nucleus will interpret this as the sound coming from the right. In transmission of sound, here are the routes by which sound waves are able to stimulate the hair cells in the organ of Corti. First, we have the ossicular route. This route is most commonly used. This is when the sound waves hit the tympanic membrane and they utilize now the ear ossicles in transmitting the vibratory force going into the cochlea. Next is air route conduction. Recall that the round window is a free membrane. It is not covered by the ear ossicles, such that if air pressures or vibratory pressures that travel through air are strong enough to allow the round window to vibrate, then this vibratory force will be transmitted into the cochlea. Then we are able to hear the sound. Now, some hearing aids employ air route conduction for the patients to hear. For osseous route of transmission, we employ the bone. Take note that the cochlea is housed within the temporal bone, such that if the vibration is transmitted through the bone, then the temporal bone would vibrate. In turn, that will cause the cochlea to vibrate as well. This is commonly employed when we use the tuning fork test in determining hearing. This is now the ascending pathway for hearing. Signals coming from the cochlea will be carried by the acoustic division of cranial nerve 8, which will then ascend into the temporal lobe. In the temporal lobe, we have Brodmann areas 41 and 42, so this is the primary auditory cortex. Signals are also sent to Brodmann area 22 or the Wernicke's area. This is now the association area, which will extract meaning from the sound we hear. In the clinics, if there is a lesion in Brodmann areas 41 and 42 or the primary auditory cortex, then the patient will not be able to hear. However, if these areas are intact, but Brodmann area 22 or the Wernicke's area is affected, the patient may be able to hear, but is unable to understand or interpret the meaning. Here is another diagram for the ascending pathway for hearing. Take note that you have three sites wherein signals are sent to the contralateral side. You have the trapezoid body, the superior olivary nucleus, and the lateral lemniscus, such that signals coming from one side would be ascending bilaterally. So both right and left primary auditory cortices will be stimulated by signals coming from one cochlea. Auditory signals are also sent to the reticular activating system of the brain. This portion in the CNS controls our arousal and wakefulness. This is why sound typically should wake us up. Other areas, you have the vermis. This is the medialmost portion of the cerebellum which controls tone of the axial muscles. This is why when we hear a loud sound, when signals are sent to the vermis, it activates or it contracts the axial muscles when we hear most especially loud sounds. There are also centrifugal signals or retrograde pathways that enable us to hear sound more clearly. So these signals are sent from the cortex to the cochlea. Now, these signals are typically inhibitory in nature, such that when these retrograde pathways are activated, it decreases our hearing by around 15 to 20 decibels. So here are a few theories in tuning of the receptor system. So you have tuning of the brainstem to your hair cells, shortening of outer hair cells, and changes in the stiffness of the outer hair cells. An example of this centrifugal or retrograde pathways would be, let's say, when we are listening to an orchestra and we pay attention to a particular instrument like violin. You would clearly hear the violin, and the retrograde pathways would decrease our hearing with respect to the other instruments by around 15 to 20 decibels. Now let's talk about tests for auditory acuity. Here are two antiquated examples. The problem with these tests is that the assumption is the examiner would have a normal ear. So these two tests are not used widely anymore. For the whisper test, it is expressed as a fraction, and it is said that in a suitably quiet environment, a whisper can be heard at around 30 feet. Now for the tuning fork test, the patient is allowed to hear the tuning fork, and this is compared to that of the examiner. So again, the degree of hearing loss is determined by the difference between the patient and the examiner. And the problem for this test, other than the assumption for the examiner having a normal hearing, is that activation of the fork would not be the same for the patient and the examiner. Now, the gold standard for testing for auditory acuity would be audiometry. Now, this is done in the clinics and it can test for air conduction and bone conduction. It usually employs varying pitch and varied intensities. Now, you can test the right ear or the left ear. Now, in this diagram, here you have typical examples of an audiogram. This will note if you have certain types of deafness. For example, when you have sensory neural hearing loss, note that both air conduction and bone conduction are diminished. However, for conductive hearing loss, note that air conduction is diminished, but bone conduction is normal. Now let's talk about the different types of deafness. We have conduction deafness, sensory neural deafness, and central deafness. Now for conduction deafness, there is a problem in transmitting the vibratory pressure into the cochlea. And here are a few examples. The ascending pathway in this type of deafness may be intact or normal. For sensory neural hearing loss or sensory neural deafness, the ascending pathway would have problems. An example of that would be inability to produce action potentials, or there is a problem anywhere in the ascending pathway for hearing. Central deafness is the least common among the three. Under this, you have two subtypes, psychologic and cerebrovascular accident. Now, psychologic deafness could be due to some psychologic problem. For your CVA or your cerebrovascular accident, this is the least common because it would require damage to both right and left auditory cortices to produce this kind of deafness. Recall that signals ascend bilaterally. So when the patient suffers from a stroke and one of the temporal lobes are damaged and the other one is intact, the patient is still able to hear. However, if both auditory cortices will be damaged, then the patient will have central deafness. Now let's talk about how to screen for deafness. Again, take note that audiometry is the gold standard for assessing for auditory acuity, but not all doctors would be procuring an audiometer. However, you can use a tuning fork in assessing for deafness. In order to do this, we perform the Weber test and the Rene test. First, we perform the Weber test. We activate the fork and place it on the forehead midline. Ask the patient if he or she is able to hear the sound clearly. If so, ask for laterality. Is the sound much louder compared to the other one, or do both ears hear the sound clearly? If both of the ears are able to hear the sound clearly, then you can stop the test. The patient may have normal hearing. However, if one of the ears is able to hear the sound more loudly compared to the other, that is when we perform the Rene test. We perform the Rene test to the ear where sound has lateralized. So to do this, you activate the fork and place the fork on the mastoid. This is bone conduction, and the patient should be able to hear the sound. Ask the patient when the sound would disappear. After that, place the prongs of the fork in front of the pinna. This is air conduction. Normally, the patient should be able to hear air conduction. Now, the normal result would be air conduction is greater than bone conduction. So this is a positive Rene test. After performing the Rene test, we should now be able to diagnose if the patient has conductive hearing loss or sensory neural hearing loss. If the Rene test is positive, meaning it is normal, having air conduction greater than bone conduction, then the opposite ear has sensory neural hearing loss. If the Rene test is negative, meaning it is abnormal, or bone conduction is greater than air conduction, then that ear has conductive hearing loss. If you are still confused on how to screen for deafness using the Weber and the Rene test, look for tutorial videos online. This ends the lecture on physiology of hearing. Please read about physiology of taste and smell. You can use Guyton or Byrne and Levy. Thank you for listening.